residential congregate settings in New York City. I want to welcome you to the webinar. This is the third in a series of congregate care webinars brought to you by the New York City Department of Health and Mental Hygiene. My name is Kristen Woodlock, and I am a COVID-19 volunteer with DOHMH. Your panel for today will be Shama Ahuja and Jean Sullivan-Meissner, who are with the COVID-19 Congregate Settings Investigation and Response Unit, and also Heather Papowitz, who is the COVID-19 Hotel Program Lead. To offer a welcome to everyone today, I'm pleased to introduce Dr. Hillary Cunnins, who is the Executive Deputy Commissioner for the Division of Mental Hygiene with the New York City Health Department. Hillary?
Thanks, Kristen. Good afternoon, everyone. Thanks very much for joining. I see there are still folks logging in. We're very pleased to welcome you to this afternoon's webinar, as Kristen mentioned, the third in a series that we have conducted regarding managing of COVID-19 in congregate settings. This webinar will be focused really on the next phase of our collective work together, which is reaching a point in the city where we are able to suppress transmission of COVID-19 through testing and contact tracing, as well as continuing to offer isolation options. And I'm so pleased to be able to further introduce Shama, Jean, and Heather, who will be presenting the details of that program, and we will all be available afterwards for some questions and answers. I also just want to thank everyone who's joining us this afternoon. I am imagining that most of you are from or running or working in congregate care settings, particularly from the behavioral health sector, and we are very much aware and very grateful for the incredible work and dedication all of you have been implementing and caring for folks receiving services in the mental hygiene sector. So thanks for spending another hour with us, and I'll now turn the presentation over to the team.
Thank you, Hillary. Just to cover some housekeeping items, I want to let you know that our understanding of the COVID-19 pandemic is rapidly evolving. I think that is a fact that we have all become very familiar with. And this presentation today is based on our knowledge as of June 23rd, 2020 at 10 a.m. Again, as a reminder, all participants will be muted, but we do plan to have time for questions and answers. And we ask you at any time during the presentation, you don't have to wait till the end, but at any point in time, if you have a question, please feel free to type that in the Q&A box. In terms of the agenda today, we'll first start out with some background and some updates around COVID-19. We'll then talk about case investigation and contact investigation in residential congregate settings. Then we will provide information on New York City Health and Hospitals Take Care with the isolation hotels, and then we'll move on to your questions and answers. With that, I will turn the ball over to you, Shama.
Hi, good afternoon, everybody. I'm going to kick us off with a little bit of background and on the COVID epidemic here in New York City, and then talk a little bit about contact investigation. So the COVID-19 pandemic continues worldwide, as we all know, and New York City has been the epicenter with over 209,000 cases and over 21,000 confirmed and probable deaths attributed to COVID-19 among New York City residents. And these numbers are as of yesterday at 1 p.m. And of course, you can go to our website for daily updates on all of these numbers. So every New York City neighborhood has been impacted, as you can see on this map. Case rates range from 582 per 100,000 in neighborhoods like Battery Park City, all the way up to in excess of 4,000 per 100,000 in East Elmhurst, Corona, Jackson Heights, and then in northeast sections of the Bronx. When we look at the trend over time, you can see on this epidemic curve that we've made incredible progress since the peak of the outbreak on April 6th, when there were 6,374 cases diagnosed in a single day in New York City. Now we are all the way down to about 160 to 300 cases diagnosed per day as of last week. This was, of course, the result of mitigation efforts put in place by instituting pause or the stay-at-home orders that we've all been maintaining to ensure physical distancing in New York City. This figure just shows you the phases of the epidemic as outlined by our colleagues at Vital Strategies. The first phase of the response, when there were no cases, is really when we are in a preparedness phase. Then once we start to see sporadic cases, we move into containment. And if we're not able to contain cases, we typically start to see clusters of cases. And then in the mitigation phase, we see numbers of cases growing, and that is usually evidence of local transmission. By the time we're at the peak of the outbreak, we were well into widespread community transmission, at which point it was very difficult to control the outbreak, particularly when we don't have widespread testing available or any pharmaceutical interventions like treatment or vaccine, as was the case with COVID-19. However, due to the stay-at-home orders, we have been rapidly on the decline over the last couple of months, and now we are entering into a suppression phase of the epidemic. Unfortunately, our work doesn't stop here. We need to maintain vigilance and to try to mitigate a second phase of the epidemic. The way that New York City is doing that is through a multi-pronged strategy of testing, tracing, and taking care of New Yorkers while they need to isolate or quarantine following their COVID-19 diagnosis. Here's what's involved with this strategy. In terms of testing, the idea is to rapidly expand COVID-19 testing to detect infections. When we say trace, we're talking about identifying those cases, identifying their associated contacts, and then recommending isolation for the cases or quarantine for the contacts. Take care is really referring to connecting New Yorkers to the resources that they would need so that they can safely isolate or quarantine at home or in a hotel. So now I'm just going to briefly summarize the current New York City testing recommendations. I just do want to note that it's important to consult with your federal, state, or city funders or any licensing entity that you might have related to programmatic requirements on testing for COVID-19. But in general, the New York City testing recommendation is that all New Yorkers should receive a COVID-19 diagnostic test. Repeat testing should be considered if a person's previous test was negative, and if they have symptoms of COVID-19, if they were exposed to someone who's suspected or confirmed to have COVID-19, or if they're planning to visit someone at the highest risk for severe COVID-19 illness. For example, people older than 65 years old or people with serious underlying medical conditions. Some of the symptoms for COVID-19 are cough, shortness of breath or difficulty breathing, fever, chills, muscle pain, sore throat, a new loss of taste or smell, and then some of the less common symptoms that have been reported include diarrhea, nausea, and vomiting. Older adults may also have some atypical signs or symptoms such as delirium or falls. As part of the test strategy, widespread testing is now available across New York City. This is through walk-in testing that's available at the health and hospitals, public hospitals, and clinical sites. There's also free testing, which is available by appointment for essential workers and vulnerable populations. Capacity for on-site testing is expanding citywide, but it's not yet widespread and cannot accommodate individuals with mobility or other issues who would not as easily be able to access these resources. However, we hope that that is going to be changing going forward. So now I want to talk a little bit about contact investigation, and I wanted to use this figure to review some of the key concepts. So when a person becomes infected with the virus that causes COVID-19, that is the start of the incubation period. And this incubation period is the time between exposure and onset of symptoms. That usually lasts about 5 days, but it can be anywhere from 2 to 14 days. Once a person develops signs and symptoms, their illness can go on for anywhere from 10 days to more than 2 weeks, depending on severity of their illness. The time from when a person, the time when a person can transmit an infection to others is called the infectious period. And that this red area right here represents a window of opportunity before a contact becomes infectious, where we can ask them to quarantine to ensure that they do not transmit virus to others. That is why contact tracing is a key intervention that can help us interrupt transmission. Oops. So now I just wanted to review some of the key steps of contact investigation as outlined by the Centers for Disease Control and Prevention. So contact tracing starts with a positive test result, which indicates a new case. The individual is interviewed by public health staff and educated about the importance of isolating to prevent transmission. The person is asked to recall everyone that they had contact with or close contact with during the time that they may have been infectious. These contacts are then notified of potential exposure as soon as possible. Contacts are provided with education about quarantine, risk, and connection to testing if it's indicated, and other services. Contacts who develop symptoms are advised to isolate, and then they're referred for testing and are evaluated for the need of medical care. Some of the core principles that we employ when we do contact investigation is ensuring that we protect the case's confidentiality. We also want to ensure that we approach cases and contacts in as sensitive a manner as possible, and we also want to promptly identify and act on any new illness that we see among contacts. This is really important, especially to prevent future cases and to break the chain of transmission. We want to provide comprehensive wraparound services so our additional interventions are safe, feasible, acceptable, and effective. The New York City Health Department staff routinely conduct contact investigation for diseases such as tuberculosis, HIV, other sexually transmitted infections, and measles. So with COVID-19, as I mentioned earlier, we don't have pharmaceutical interventions, so we really need to rely on the public health intervention of contact investigation, isolation, and quarantine. This cartoon just demonstrates that stopping one chain of transmission can really prevent many future cases. The more chains of transmission that we can stop, the more future cases that we can prevent. So with that, I am going to hand it off to my colleague, Jean Sullivan-Meissner. Thank you so much for your attention.
Hi, everybody. Thanks so much for joining today. As Shama mentioned, I'm going to provide an overview of our planned approach to case and contact investigation in residential congregate settings in New York City. So recognizing that this process will require a tailored approach that reflects understanding of the regulatory environment across diverse setting types, medical, behavioral health, and social service needs among residents, additional infection control considerations that might be important, and unique challenges to isolation and quarantine, the Health Department has assembled a dedicated unit to work closely with facilities and programs to conduct case and contact investigations. This approach really builds on the existing relationships and collaboration between programs and the Health Department that's been occurring throughout the outbreak, and will focus on identifying and preventing transmission at the facility level and providing support to congregate programs. Hillary mentioned this earlier, but we know that all of you have been working incredibly hard over the course of the outbreak, and our goal is to work with you and to support your continued efforts to care for your residents and staff. Just a quick note here, and I'll talk about this a little bit later as well. Contact tracing is happening citywide, and contact tracing among individuals who do not live in a congregate setting will be conducted by the New York City Health and Hospitals Test and Trace Corps. Our group has been and will continue to work closely with that team, especially in terms of referrals and notification related to staff and visitors and others that are not living in the facility itself. So just a quick overview of the site types in our purview. They include residential programs licensed or funded by the New York State Office for People with Developmental Disabilities, residential and crisis treatment programs, including sites licensed or funded by the New York State Office of Addiction Services and Supports, residential programs licensed or funded by the New York State Office of Mental Health, residential programs funded by the New York City Health Department, New York City Department of Youth and Community Development residential programs, New York City Administration for Child Services residential programs, shelters, correctional facilities, nursing homes, and adult care facilities. Just to describe our core objectives, we really want to ensure timely investigation of people infected with SARS-CoV-2, the virus that causes COVID-19, people who have been exposed to SARS-CoV-2, and people at high risk for poor outcomes. We're aiming to lower the risk of transmission among residents and staff, to ensure continuity of essential medical, behavioral health, and social services, to build capacity within settings to support outbreak preparedness and prevention, and to promote equity, respect, and dignity across all of our activities. Our core activities include identifying cases of COVID-19 occurring in congregate residential settings, and we're going to do this in a couple of ways. The first is through a residential address match, in which we can identify individuals that are living in a congregate facility. Those individuals will be referred immediately to our team, and we'll reach out to the facility from there. They may be identified through a case investigation interview, in which they respond that they are either living or working in a congregate facility, and or if you or your programs or other providers reach out to the New York City Health Department to notify us that a resident or staff member with COVID-19 is connected to a residential congregate facility. We plan to work closely with state and local agencies. As Shama mentioned earlier, it's really crucially important to us that our teams and our investigators have an understanding of the regulatory environment, of the different regulations and policies, not only across facilities, but across city and state agencies. We'll be notifying and coordinating closely with facility management. We want to ensure confidentiality, as we said, of both the patients and their contacts. We want to identify and address barriers to effective isolation and care, and we want to work with the facility to assess resources and needs that might support effective contact elicitation and monitoring. Through this process, we'll be conducting case investigation interviews and assessing possible transmission. We'll be identifying contacts and facilitating contact monitoring, and this will occur both in conjunction with the facility and in partnership with the contacts themselves. We'll be providing technical assistance and support, and this will really mimic a lot of the work that we've been doing throughout the outbreak, where we work with facility management and others on site to provide isolation and quarantine recommendations, to provide behavioral health support, and to recommend environmental and other infection prevention and control. As needed, and my colleague Heather will talk about this a little bit more in detail, we'll be facilitating transport of residents to other facilities if indicated for optimal management, including for isolation and quarantine. We'll provide educational materials about COVID-19 to residents and staff to assist with the development of a communications plan if needed. And then, as I mentioned, we'll be coordinating case and contact referral with the New York City Health and Hospitals Test and Trace Corps, and this includes site staff and visitors and other non-residential contacts. This is a collaborative process, and we really feel that it's important to work closely with facilities and programs. We want to understand your needs. We want to understand the best ways to implement this process, given your unique circumstances and populations. We're recommending that if possible, that you designate at least one point of contact at your organization. That would be the individual or individuals that we would reach out to when making our first contact with the facility. We also recommend that if possible, and I know a lot of you have been doing this work for months and are very well familiar with staffing needs and space considerations for isolation and quarantine, and already have communication plans for staff, residents, and families in place. But to the extent that you can continue to plan, given this new scope that includes case investigation and contact monitoring, we encourage you to do so. And then finally, if you have questions, we have a newly developed email address, which is listed here. You can also reach out to us at any time through your existing contacts at the health department. We'd be happy to talk through some of our processes to work with you to figure out what works best. And we're really excited to do this work with you all. With that, I'm going to turn the presentation over to Heather to talk a little bit more about the H&H isolation hotels and the process for referral.
Great, many thanks, and it's a pleasure to be here. As Jean said, I'm going to provide an overview of the New York City Health and Hospitals Isolation Hotels. And I just want to give a quick thanks to the H&H team for providing the content of these slides and also providing the service for New Yorkers through this COVID response. So just to give a brief overview, the goal of the hotel system is to reduce spread of COVID-19 within living spaces and in doing so the community. And this is done through providing free hotel rooms for people who need to isolate or quarantine due to COVID-19 but cannot do so where they live. And this is people living in settings where there's multiple people, where they've shared kitchens, shared bathrooms, where it's difficult to isolate in the residence. And this is really provided for people who have COVID-19 symptoms or contacts of people with suspected or confirmed COVID-19. So just to take a quick look at the hotel experience, and we really want to provide an environment that's conducive to maintain isolation for the 14 days. So on arrival, the resident will meet with a social worker and they will conduct a psychosocial assessment and coordinate with the referring agency. And this is really to take a look at their life, their work, their home life, and what the needs they will have while they're isolating within their hotel. So they work closely with them and with the referring agency on this. 3 meals are provided a day and they're delivered to the person's room. And there's also option of other types of food depending on the resident's needs. There are air conditioners, which is really important right now, as you can see. There'll be Wi-Fi, cable TV, and local phone service are available. And this is also really important to contact with their family and also with their provider and other case management services. Children can accompany the residents. Either they stay in the room, or if there's a number of children, you can have adjoining rooms. There'll be regular wellness checks, and this happens throughout the day. And they're really looking at the health and well-being of the resident while they're staying at the hotel. And there's also access to video conferencing with providers. And this also includes psychiatry as needed. There's 24-hour nursing service for any emergencies or questions. And there's also pharmacy services. So they access pharmacies in the location, and they can also deliver that to the person's room. And they provide transportation to and from the hotel as needed. So how do you access the hotels? There's 2 different ways. Number one is you can send an encrypted email directly to the email presented here. And here you'll just include a number of items, such as the client's name, date of birth, telephone, and the facility's telephone, supportive housing or residential treatment provider and program name, and contact number of the provider who will be completing the screening with the resident, and if the patient has any medical issues that need attention, to obtain written consent. So this can be brought with the resident when they go to the hotel. You can also access the hotel through calling this number. And when you make this phone call, you'll be talking to an H&H provider, and you'll speak with a nurse who will walk you through the process. After the email or call, a community care nurse will contact either you or the client within approximately an hour. And there'll be a screening process to see if they qualify for the hotel or another level of care. And again, the H&H Contact Center will provide transportation within 1 or 2 hours as needed. So the duration of stay. Guests with a possible or confirmed COVID-19 who are in the hotel to isolate will check out when the following criteria are met. This is based on UHMH guidelines. It has been at least 14 days since symptoms began. There's absence of fever for at least 3 days without antipyretics, Tylenol, and overall illness has improved. The guests who are in the hotel to quarantine, if they're a contact, can check out if it's been up to 14 days, or if their home circumstances improve, they can also return home to self-quarantine. And then continuative care. So while they're in the hotel, the referring agency is expected to continue providing care, such as follow-up calls, televisits, or in-person visits. If the client has home care, you can coordinate with the New York City Health and Hospitals program to transfer that care to the hotel. Guests will receive clinical supportive services while in the hotel, but are instructed to call their primary care provider as needed, either for follow-up or as needed based on their condition. The referring agency is welcome to also visit a client in the hotel, but they'll have to bring their own PPE and proof of malpractice or indemnity. And while in the hotel, the guests, if there is a medical emergency, they will be using 911 to manage that. But there's also, again, as I said, there's on-site staff on both on each floor. There's a floor monitor, and there's the nursing staff that are on. And so what should the guests bring? Photo identification, if they have one, a 14-day supply of medications, clothes, shoes, and other personal items that they'll need for a 14-day stay. This also includes dentures, hearing aids, and other medical equipment. And anything they need for their own enjoyment while in 14 days in the hotel, cell phones, laptops, chargers, books, magazines, or anything they'll need. A small amount of cash or a debit card, and if recently hospitalized, discharge paperwork or medication, as well as other items such as a wellness recovery action plan or crisis plan, if applicable. And this is actually more geared towards you and the healthcare workers and other workers providing services in New York. There's also a hotel program that provides hotel rooms free of charge for anybody who is eligible, and the eligibility is as provided in the slide. So they're currently employed or volunteering to provide care services in any of these settings: healthcare settings, congregate care settings, shelter settings, home-based care. Currently do not have COVID, so these aren't COVID-19 or contact hotels. These are really for providers working in these settings who temporarily cannot live at home, and they need to continue to work to provide these services to New Yorkers. So we'll provide the resources and links to this into the next slide. So I'll transition back over to Kristen and just let you know about that.
Terrific, thank you. Okay, in terms of resources that we have here, we have free walk-in testing that's available in New York City Health and Hospitals, public hospitals, so we've given you the link for that. I will tell you, for those of you who are trying to write furiously, we've had a few questions about, will the presentation be available? And yes, the presentation is being recorded and also will be available on the website in the same location as the other webinars that we've done in this series for Congregate Care. So again, these will be available to you. Additional resources we have are free testing by appointment for essential workers and for vulnerable populations at One Medical. So we've given you the link for that. Promoting physical distancing in residential settings, some tips and ideas for doing this. Isolation hotel program for those with COVID-19. And then the last piece, the hotel portal for essential staff, the New York City Emergency Management link. And finally, the Test and Trace Core with New York City Health and Hospitals websites, where you can find good information. So those are our resources. We have some questions to start off with. I will remind you, if you have questions while we're going through these, feel free to type them in the Q&A box, and we'll get to them, as many as we can during the time that we have. So again, just to reiterate, because there have been several questions about the slides, the slide deck will be available at our website, and also this webinar is being recorded. So the first ones are probably for you, Jean. There's a series of questions that relate to the congregate care unit. The first is, if a person who tests positive lives in a congregate setting, will that agency be contacted as well as the patient? And what happens if the patient doesn't have a phone number?
Hi, thanks so much. So the answer is yes. We'll be reaching out to the program directly to work with them and also to the case patient. If the individual does not have a phone number, our goal would be to work with the facility to see if they can help to connect us to the patient. In some settings, this may be applicable to some of the folks on the line. We recognize that individuals may not be able to be interviewed directly, in which case we would try to work with the facility to identify an appropriate proxy and to ensure that all of the appropriate consents are in place.
Great, thank you. Do you know if it is the congregate unit working with programs that are in the HASA area, which is the HIV or AIDS Services Administration?
We are, and yeah, I'm sorry, that was an omission on the list. Yes, we are. I know there are a couple of congregate settings, 12 maybe, under the Ryan White, and also at least one congregate setting in the HAPWA realm. So we'll be working with those settings as well.
Okay, thank you. Got two more for you, Jean. The next one is, how does 42 CFR Part 2 impact trace investigations? And is it possible to release the identity of a person who has tested positive or who may want to have contact with the tracers without that patient's consent?
Sorry, so I just want to understand. So the question is related to, because of these specific protections, what is their public health law, or what's the ability of the facility to disclose that information?
Correct. How does that affect the work of the unit and the trace investigation?
Yeah, I mean, I just want to say again that we take patient confidentially. It's just of the utmost importance to us. We're really cognizant of this in the health department across all of our contact tracing work. We'll be working with the facility directly. We are, due to public health law, generally the disclosure of patient information to the facility and to the facility only, with express instruction that that patient's identity will stay confidential, is permissible under public health law. And so that would apply also to the identification of contacts. I'm going to actually turn it over to Shama, who might be more well-versed in this, but we can follow up and get some more specific language around this and send it out to everybody if that's helpful. The other thing I just want to say is that part of our staffing, our staff for this unit are coming from across the health department, and our goal was really to match individuals who have been already working very closely with sites by category, so that they're very well versed in the laws and regulations and privacy protections across these setting types. And so the individuals who will be doing outreach, for example, to residences for individuals with substance use disorders, are folks that are already working in that realm. And same goes for the contact tracers. We're really aiming to have a peer specialist approach, just recognizing that an understanding of the site types and of the regulatory environment of all these kind of complicated protocols related to very specific populations, so that we're just making sure that we're adhering closely to those needs and those regulations. I'm not sure if I totally answered the question, so I'm going to,
let me jump in before you move that over to Shama. There was a clarification from the person who asked the question that that they were really saying, as an agency, if one of the patients that I'm working with has tested positive, do I need a consent to be able to tell you, to notify the health department?
Hi, it's Shama. So if you have a concern about a patient, you are always welcome to call us, and we can discuss it with you. We are allowed to get that information, both from providers and anybody. I'm sorry, I have some construction in my building. Both from providers and anybody that is wants to, report on a case. But like Jean said earlier, we don't redisclose that information unless there is an express public health reason to do so. So if we're trying to control transmission or prevent transmission in a facility, that might qualify as a reason to disclose that information. But in terms of giving that information to us, you don't need to get the patient's consent or to, we are allowed to receive that information, if that makes sense.
Okay, thank you. Who are the congregate providers supposed to contact if they have someone who tests positive?
They can reach out to the health department.
Sorry, I was just going to say they don't actually need to, because anybody who tests positive, that information is actually reportable to the health department from laboratories. So anybody with a positive test for COVID will be reported to us, and you actually don't need to let us know. If you want to let us know, or if you have a concern, you can certainly call us.
Yeah, and I'll just add to that. I mean, I think we would encourage facilities to call us, especially if you need help, need support, want to talk through what the isolation and quarantine and next steps for your facility in order to help you manage and to sort of think through next steps once you have an individual, whether it's a staff member or a resident with COVID-19. The best way to get in touch with us is through the provider access line. So I'll say it now for those of you who are able to document it, but we'll also send it out to folks if that's helpful. And you can also find it on the New York City website. So that number is 866-692-3641. And that way they will connect you directly to our team. The other thing I would encourage you to do, for those of you who have contacts in the health department, of course, they can also access us if you're working with them directly and need more information.
Thank you. Thank you for that. So a couple of questions related to testing. So this question is, why would we be recommending 100% of testing? Are you doing that from a New York City perspective for a data purpose? And asking that question in the context of, if we are tested, that doesn't see, my understanding of the guidance is that doesn't prevent future transmission or reinfection. So I think the question here may also be answered and be helpful if someone could speak to the difference between the diagnostic testing and antibody tests. Would somebody be able to respond to that?
Sure. I'm going to actually flip that one over. We've got a couple of our medical epidemiologists on the line, so I'll defer to them to answer that one. Ann or Dan, are you on?
We may have issues with muting. I don't hear them.
Hi, this is Hank. Daniel, I will unmute you. Daniel,
Great.
you should be on.
Hi, can you hear me? This is Dan.
Yes, we can, Dan. Thank you.
Oh, great. Dan Aris. Thank you. So in terms of testing in the facility, let me just understand correctly the question. It's to why would we be recommending testing for all residents, and in what setting do we do retesting? Is that the accurate?
I believe it's the first part, yes, and then it seemed to me the question might have had some confusion about the difference between diagnostic testing and the antibody testing. Asking that, why are we doing 100% testing if we're not sure if the testing will demonstrate that you would be able to prevent future reinfection or transmission?
Okay. All right, good. Yeah, so that's a good question, and it's somewhat nuanced and actually changing somewhat rapidly. But The short answer is, the unit is going to essentially recommend testing when it benefits the contact tracing. So when there is a case and it's identified that there are people around that person who were exposed, then very likely we're going to recommend that some or all of those individuals will be tested, and again, that's to determine how far the exposure might have spread. But it's not necessarily everyone in the facility is going to be, sort of automatically tested. Again, that's going to be sort of based on the outbreak or cluster, et cetera. And then, as was mentioned, there's a couple of different types of tests. There is essentially a direct test, a PCR test looking specifically for evidence of the virus, and that's essentially like think about an active infection. So that person has the infection at that moment. And that is different than what we call the serology test or the antibody test, which is really kind of an indirect test looking at the person's immune system response to the infection. And generally, that is essentially evidence of an older infection. So in other words, the person had the infection or had the virus and potentially doesn't have it anymore, but there is still evidence that the person was infected. It is true that doesn't necessarily mean the person is immune, though. That's sort of a complicated thing. Just because they have antibodies, it doesn't mean that they are immune, and it doesn't mean that they can't get reinfected. So those are kind of nuances that we'll have to kind of take into consideration with each investigation. Hopefully that wasn't too confusing. Let me know if there are any other questions about that.
I will. Thank you. Thank you, Dan.
Sure.
Shifting over, Heather, to a few questions on hoteling. The first one is, will staff be allowed to work in the hotel settings if clients need to go to one of the hotel settings? And the specific example in the question was if the individual, the client, is served in OPWDD, again, will staff be able to be there with that client?
So staff are able to go visit, as mentioned in the slide. And they're also able to have a caretaker. So there's a possibility if they do need a caretaker, they can stay with them in the H&H hotel. And they do have some hotels with adjoining rooms to help with that. So there is some capacity for that. And that's something you should talk to H&H on the initial discussion when you call or write the email. A good question.
Thank you, Heather. The second question was asking if you could speak a little bit so that the audience could understand how people really are in the hotels in terms of can they come in and out, can they bring alcohol into the hotel room? So a question more on that of like what are those 14 days like for that person in terms of their ability to move around?
Yeah. I mean, I can imagine it's not easy, but H&H does a pretty good job of providing them a environment that's conducive to that. They should not leave their room, so they really should isolate. However, if they need to go out and have a cigarette, they can be accompanied by one of the hall monitors and go out. And of course, they can leave if they need to seek medical care or have dialysis or whatever they need to do, as long as they're accompanied and they're covered with masks and following infection control precautions. So and then they check on them a lot, and they have again this hall monitor that goes and talks to them through the door or calls, and so they have quite a few things going on during the day. And they really want to make this a suitable environment to maintain that isolation and quarantine for that time period. As far as I think the alcohol was asked in this question, this is actually a really good question, and it's something that the team here actually at DOHMH is working on really hard to try to get guidance around the use of alcohol. Right now, it's not allowed, but if there are some addiction problems, especially how to manage that safely within the hotel environment. But that's a very, very good question and something that the team is working on closely right now.
Great. Thank you, Heather. Appreciate that. A couple of questions back on contact tracing. One is just to be clear on this. Will the contact tracing go back to the beginning? So will the contact tracers come back to the congregate settings for people who perhaps had symptoms, weren't tested, and then were confirmed sometime in April, or is the contact tracing just for new cases or more recent cases?
This is Jean. At this point, it'll be just for new cases, so this will be a prospective process.
Great, thank you. And another question on the contact tracing. What are some questions, help us understand what this experience might be like for us? So when we do get a call from the unit, what are some questions or information that you might be asking us when you contact us so that we can begin to think about our procedures and our processes and understand that a little bit more?
I'm actually going to turn that one over to Anne if she's on, because she's been working closely with us on our questionnaires and protocols.
Hi, yes, Anne. I just joined. Can you hear me?
Yes, we can.
Okay, great. Yeah, that's a really good question about what kinds of questions we'll ask. And so I think the first set of questions will be related to the facility to help our team understand what kind of recommendations we should make. So for example, what kind of facility is it? How many rooms? Are patients in single or double rooms? Do they share meals in a congregate setting? Those kinds of questions. We'll ask questions about previous cases in staff and in other residents, maybe the question about how long since the last case. So we'll ask facility level questions first, really for the purposes of giving appropriate infection control guidance. Then we will ask a short set of questions about the individual who was a confirmed case. And I think, as Jean mentioned, ideally we'll speak to the individual, him or herself, depending on the type of setting. But we know that in some setting types, that individual may not be able to provide that history. And so then we will either speak with a proxy for that individual or with the facility director if that person has the most up-to-date information, for example, about symptom onset, date, and other limited questions about that individual's illness. And then the last set of questions that we'll ask will be to understand who came into contact with that patient, with the patient who has confirmed COVID. And so we'll ask for the person with the most knowledge of that. Usually we'll start with the facility director, but we'll also ask the case patient who had close contact with this individual during the period that this individual was contagious. And we will ask for information about, some brief information about those individuals. So that's the three levels of questions we'll be asking: facility level, case, patient, and contact.
Great. So another question about how this how is this process going to get started? There's a few questions that are in the same vein here about just walk us through one more time about how this process starts. So do we as providers need to call the team in terms of letting you know that someone's tested positive, or if you get that lab result that you talked to us about, Jean, and that starts the process, again, who are you going to call in the agency, and just walking through that process of how are we going to connect with each other one more time.
Sure. So the most likely way that we'll find out about an individual who resides in a congregate facility is, as you said, through an address that comes with the lab report. Because COVID is reportable by labs to the health department, we'll have that information. That will help us identify the facility. And so we have a list of facilities by address type. We have teams that will reach out directly to the facility. And this is where if you are able to identify a point of contact at your facility, that will be so helpful to us. We want to make sure that we're reaching out to the right people. We'll reach out to the facility, notify you of the individual you may already know, as you indicated. And then, as Anne said, we'll work directly with the facility to collect information about the facility itself, to ask about infection control practices, what you've got in place so far, make some recommendations about isolation for the individual, and then ask about possible transmission and try to get a sense for who that individual may have spent time with. We'll then be working with the facility as needed or call directly to the case patient to ask a couple of questions about, again, who that individual may have spent time with. And then depending on the nature of the individuals in the facility, we'll be working closely directly with the contacts or with the facility to do monitoring. So this is going to look different depending on the facility type. So in nursing homes, for example, it's likely the facility staff who will be doing the contact monitoring because they're already closely monitoring symptoms, because they're already working so closely with their residents. In facilities where individuals are more independent, our team of contact monitors and investigators will reach out directly to those individuals.
Thank you.
Yeah, you know what I didn't address is for people calling in. I mean, you know, because we're reliant on laboratory results and the timing, if a facility knows that they have either a resident or a staff member who's positive, they can reach out to us. The process will look very similar. It will just start that much earlier. Do you know what I mean? And so if individuals and facilities know about a case in their facility, they certainly can reach out to us, and then we would then assign that facility to a team, and they would do the same process, work with the facility on infection control, on isolation and quarantine, on identifying resources that might be needed to support both the staff and the residents.
And Jean, can you just share with us again what is considered a close contact?
Sure. So the definition we're using in New York City right now is 10 minutes or more of contact with an individual within about 6 feet. So that's the working definition in New York City right now. We recognize that this, you know, that's very technical and specific, and, you know, we want to work with facilities to identify people who might be at the most risk of exposure and at the highest risk for poor outcomes, but that's our general working definition.
And is there any distinction about if that person is wearing a mask or a face covering?
I'm going to flip that one over to Anne and Dan, our infection control specialists.
Dan, you want me to try that one? What I will say is that in healthcare settings, the CDC has set up some guidance specifically related to healthcare workers, and they do take into account use of PPE for healthcare workers. And certainly in Article 28 facilities, it is likely, although it's not final yet, that New York State, which has the regulatory authority, will go along with the CDC guidance. So they do take into account masks and other PPE. On the other hand, our colleagues at Health and Hospitals who have begun community-wide contact tracing are not taking into account face covering, and so it's likely that we will follow suit with that, and we will define close contact regardless of the face covering.
Got it. Thank you.
Hey, Kristen, this is Jean. Before you move on, I actually want to touch on one really key additional way that we might learn about a case, and I mentioned it briefly in the slides, but I just want to point it out again. In some instances, especially for whatever reason, we don't have the right address match or we don't have information, an individual, we may learn about an individual, and this will be especially true for staff members. We will likely first learn about that because that individual has been referred from the health department to the New York City H&H Test and Trace Corps. They will be reaching out to that individual, and it's possible that they will be the first person to reach that individual. They ask a number of questions, and those questions include, do you live in a congregate setting? And then they describe that a congregate setting is a place where people might work or live in close contact, share bathrooms, kitchen, common areas, and then they provide a number of examples to help people identify whether they themselves work or live in a congregate setting. In those instances, they will refer those facilities back to the health department so that we can reach out. But I just want to make sure that you know and that you have the expectation and that your staff knows that that is likely the entity that will be reaching out. Similarly, when we're talking to you, if we identify individuals who are not residents of the facility, we will be referring those individuals to the Health and Hospitals Test and Trace Core for monitoring and for interview. And the reason, especially for individuals who are cases, is they will likely have contacts who are outside of the facility. So again, we're concentrating really on the facility level transmission, though they'll be interviewed by the Test and Trace Core to identify additional contacts. So their households, for example, leisure contacts, other folks that they may have been in touch with.
So I'm going to ask you to say that one more time, Jean. I know you're because I
that's
think
okay.
Just on behalf of those who are listening, and I know that there's a lot to comprehend there. So just about somebody who is a resident in one of the congregate care settings. This is how you're likely to be notified. And if I have a staff person who's working in that residence, just run through that whole cycle one more time for us.
Sure, and I know that this part makes it feel particularly complicated. And so if there is an individual who resides in a congregate setting and we can match the address within the health department, those individuals will be referred directly to our team and will reach out to the facility. If the individual is a resident whose address doesn't match with a known residential congregate setting, or if they're a staff member who, will put their own home address or maybe another address, those individuals will be referred to the New York City Health and Hospitals Test and Trace team. They will be reaching out directly to those individuals and conducting a case investigation interview. That interview will include questions about whether individuals live or work in a residential congregate facility. If they do, the Test and Trace team will refer those facilities back to the New York City Health Department so that we can reach out. So if it's a staff member, this is an example. If you have a staff member in your facility who's diagnosed with COVID, their lab report would come to us. They would be referred to the Test and Trace team. The Test and Trace team would interview them and continue to monitor them. But once they learn that that individual works in a congregate facility, they will let the health department know, hey, we have somebody who worked in a congregate facility. Here's the information for that facility. And then we, in turn, would reach out to the facility to work with you around infection control, identification of additional contacts at the facility.
Thank you. And just a follow-up on that in terms of staff. Can you speak, or can one of our panelists speak to how government broadly will support providers in the event that they have to quarantine multiple staff at once? Will there be guidance on that or policies support about how organizations are going to be able to meet these goals of doing this and also make sure that they're able to consistently provide essential care?
Yeah, that's a great question. I mean, I think part of our work when we reach out to facilities, and I'll say this really quickly and then maybe defer to you, Kristen, actually, I think you're familiar with some of the of the staffing supports that are available, especially in this realm. But our goal when we work with facilities is to identify exactly these kinds of needs. So that includes staffing resources, PPE. There are a couple of different resources, which I think, Kristen, you can speak to better than I can in terms of identifying potential staff to fill in for staff, especially when there's large staffing shortages. One is the New York City Healthcare Worker Staff Surge Support, which we can send out information on. And then, Kristen, do you want to speak to some of the other staffing resources that are available?
Sure. We have looked at this issue of surge staffing throughout the first wave of COVID. And have really found most organizations have been able to identify solutions about how to manage their staffing levels within their own staff and moving either clients around or having staff move and cover shifts, or through the use of temporary staff. One other thing that I would draw your attention to, and it'll vary depending on what kind of guidance you have for your program, but some regulatory bodies are speaking in their guidance to quarantining of staff who are essential during staffing shortages, and I would draw you back to that. And then just lastly, to recommend that you take the congregate unit up on their offer to try to problem solve and come up with individually tailored solutions around staffing issues when they arise in your particular program. So with that, I note that we are at 4 o'clock, and that will bring our webinar to a close. I would like to thank you for joining us today. We had over 400 individuals participating in the webinar. Make sure you look for the slides and for the recording, and we look forward to being with you again in the near future. Thank you, and enjoy the rest of your afternoon.
Hey, Kristen.
Yes.
Sorry,
Yes,
before we stop, is there, can you just speak to mechanisms for some of the unanswered questions or questions where we wanted to go back and get a little bit more information, whether there's a mechanism for reaching back to folks to make sure that we have their questions answered?
So we will have a listing of the questions, which we will use as a team to formulate future webinars. There isn't a way for us to immediately email all of the participants, but we will use your question and feedback that you've provided us to look at addressing questions in future. Right. Thank you, everyone, for your participation, and we look forward to that next webinar. Have a great rest of your afternoon.